So what's your reflection on that, David? Next slide. Joseph.
Uh, yes, you want me to discuss? I'm waiting
Yeah,
for.
anything from this, from the demographics.
Yeah, a person who has lived for 56 years, so has lived for quite some time. Accumulation of risk factors that can result into diseases. We expect them things such as chronic illnesses like hypertension or DM, which can result into other diseases. But again, uh, I think lives in and around the place that we live. A lot of the tropical area, a lot of infectious diseases is also possible. Being a cash paying patient, maybe poor attention and maybe infrequent visit to hospitals. You can have uh, things that you may see at the end, like it's different when you see a disseminated TB that's been there for 6 months vis-a-vis that's it. Yeah, thank you. So I think I'll be brief in this if complainers we have used like 15 minutes already. Abdominal discomfort. It's hard to pinpoint what's the problem. Is it abdominal pain? Is it abdominal heaviness? Is it so hard? Like what does the patient mean when they say abdominal discomfort? Is it pain or something else? So what I would do in real life, someone says I have discomfort in my abdomen. I say, what exactly do you mean? You mean is it pain or you see feels heavy? Uh, is it like what exactly is it? So I would inquire more. What does the chief complaint means? Like what is discomfort? I think we should proceed, Michael.
So the HPI.
Yeah.
So this patient keep insisting that he has abdominal discomfort, which he explained as fullness, excessive bulging, and bloated abdomen for the past 3 months. And he reports no any abdominal distension and sure of abdominal pain, and he insists more of discomfort rather than pain. But he reports no any episode of vomiting and he has normal bowel habit. But on top of that, after 1 month of this particular presentation, his wife reported to you that her eyes start turning to yellowish. And he also added on top of that, oh, I remembered, now I have also a complaint of deep yellowish urine. And then you keep inquiring if there's any history of itching skin or dermatological presentation, which were none. And he also has a normal stool colored. Proceed, David. So also report a significant weight loss over the period of the past 3 months. This is from the sun. Also, he has no history of hepatitis screening and no history of working in swamps. He has a positive history of alcohol consumption, which is controversial. So, of which the patient report to use a moderate alcohol in moderation. Meanwhile, the relatives say that the patient is using a significant amount of alcohol. Report significant weight loss over the past 3 months. His clothes are oversized, but he also reports no any episode of fever, no heat or cold intolerance, and reports normal urinary habit. The rest of the history, family and social history, review of other system and family and social history, past medical and surgical history, they are all unremarkable. Joseph.
Yeah, thank you very much. Now it's getting clear. Yeah, this is like I love this because this real life. I've had situation like this. You can have even a patient who says, "I don't know what I'm suffering from," and you have to inquire from them. So patient who is insisting that discomfort is pretty non-specific still. But Michael is taking history here, and you're presenting now the things that we medical doctors want to hear so that we can localize and find out what is the problem. And the non-specific um, stuff that she's saying about the abdomen, which means discomfort, which includes fullness, belching, bloating, very common. I sometimes have this, and maybe I say "Oh, I have eaten more than I should, and I can have something like this." But of importance, everyone here should have heard of very important thing. When you hear some any abdominal discomfort, plus what his patient is saying about yellow eyes, now you turn all the attention to the yellow eyes, um, uh, plus yellow urine. So the problem becomes jaundice, and we can communicate easily among us when we say now jaundice than discomfort. So I won't spend a lot of time trying to find out about what is causing the discomfort, but now I'll direct my attention into discussing about jaundice. And we've had quite a number of discussions here about jaundice. Um, here. So it all boils down to say, uh, what is the problem? Because when you have jaundice, when your eyes is they are yellow, it means the bilirubin is high in your blood, and the bilirubin can be high, as I said, high bilirubin or indirect high bilirubin. But it boils down to two things: is the problem the liver, or is the problem the RBCs busting up and releasing the indirect bilirubin. Um, you start sensing initially because imagine you have RBCs busting up, releasing the indirect bilirubin, and you have jaundice. You also present with anemia, and if that's an acute process, you also present with symptoms of anemia, and we haven't heard them here. And we're being told yellow eyes, patient saying abdominal discomfort. They say uh, chances are this is the liver than the blood. And we also hear other symptoms that the patient is having, like yellow urine, fem bilirubin is circulating in the patient's system, also can go through the urine, and uh, we also told the patient there's a weight loss. So weight loss is very important to this patient because when you have weight loss, it boils down to maybe you're not eating enough, or you are eating enough, but you can't take what you're eating into your body and metabolize it, or you are eating enough, you're metabolizing, you're absorbing everything fine, but you are so inflamed, your body is working more than it should. So you break down a lot of the things that you eat than you should. So in that category, you go into chronic inflammatory conditions like chronic infections such as maybe TB or um, uh, uh, histo and its friends, or malignancies. And when you talk about malignancies that causes weight loss, apart from GI malignancies, it's blood malignancies. They also can cause someone to lose weight. Um, Something else is an autoimmune diseases, or autoimmune diseases will cause patients to lose weight. So if I have jaundice, and then uh, I have jaundice, I have weight loss. I think this jaundice sounds like comes from the liver, and then weight loss. I say it's the weight loss from a problem of the liver that will present with jaundice. I don't want to start stating the differential diagnosis right now. It's too early. It will be a guesswork. So I think we can move from there. But about the issue of alcohol, yeah, it looks like that because alcohol is something like creates a stigma. Someone say, "Do you drink alcohol?" Say, "I don't drink no more," and then the family is saying drinks a lot, and if you take that into consideration as far as you think of jaundice, because everyone knows the relation between excess alcohol intake and relation to the health of the liver. So, Michael, I think we should proceed.
Yeah, thank you, Joseph. And that was a very nice beginning. So, in general exam, this patient was wasted with a deep scleral jaundice. Otherwise, height was 174 and with a weight of 55. The other vitals were within normal range and were unremarkable. So, in systemic exam, the only system which had positive findings were the upper abdomen, whereby he had epigastric tenderness and hard, firm, and tender left lobe of the liver. The rest of the systems were unremarkable. Joseph.
Yeah. Thank you. So, yeah, so the information that is coming up, we are assimilating it and updating what we are talking in the first few slides. And so we've told there's weight loss and then patient is wasted. That proves what we've already had. Plus jaundice, you see it now that the patient is a scleroictus. Of importance now is the epigastric tenderness plus the hard, firm, and tender left lobe of the liver. So our confidence that we're dealing with the liver now increases, and probably we should, for now, put aside the problem of the blood that can also cause jaundice. We talk about any cause of uh, of the RBCs breaking up and releasing bilirubin in the system. So it's not a problem of the blood anymore. This is the problem of the liver. So what are the problem of the liver that can cause jaundice? But before that, we should pause and say the patient has two findings in the abdomen. One is what you're feeling in the liver, but the other is epigastric tenderness. They all should be explained separately, I believe. So when you have abdominal tenderness, when you touch the abdomen and then there is pain, the differential diagnosis of that is to think of the pathology of an organ sitting down there, of where you are palpating, and the epigastric tenderness talk about the stomach. So what are the things there? So easy ones include maybe a PUD or gastritis, or maybe um, uh, yeah, sometimes you can have organs that you read there should be tenderness in not in the press you're talking about. I mean, maybe you have um, tenderness coming from the liver, but you feel it on the epigastrium. It's possible, although we're not reading it like that. Um, Pancreatitis also is possible. You palpate on the epigastric region and you feel tenderness. And then you had the hard, firm, and tender left lobe of the liver. The things that when you see some findings in your patient, there is something that light up in your mind, and then your job now is to go further and try to prove it, or say maybe it is not the one you're thinking of. So you find something which is hard and firm. You say maybe it's nodule of the liver, a cancer of the liver. And why is it tender? Because the capsule of the liver has pain receptors. Anything which is getting bigger and pressing out the capsule of the liver will cause tenderness. So that makes sense. And if it's the nodule or any malignancy of the liver, can it present like this? And the answer is yes. It can present with weight loss. It can present with abdominal discomfort that the patient is saying. It can present with jaundice. So that is possible. What are the other things that are possible? Because the way you are palpating and the way I will palpate, they will be different. Someone can say this, and someone might not feel the way it is. That's why at the end you should go for an ultrasound to find out what is going on. But I find it hard now to say if the finding I'm seeing on the right hypochondriac region, okay, I say maybe that's a malignant process in this patient. But how about the epigastric tenderness? I find it hard to connect the two. If the easier way is to say it's still the same tenderness felt on the epigastrium, but that would be a guesswork. I should say I believe there are two different processes. Maybe until I do some further, I believe imaging. That's where I'll I'll put my money down. Yeah, that's it.
Yes. So Joseph, will you commit to a diagnosis by using the 75% of the history and physical exam at this particular point?
So to say that I should, I maybe, if I can, commit. So I have stuff in my mind. Going back, for example, the patient with jaundice, who is wasted. There is questionable history that they drink a lot of alcohol, and what I'm seeing here is the very suspicious finding on the liver of an hepatocellular carcinoma. I can say that's what I would have in my mind. And so before doing anything, so even the most important thing tested this patient will be an ultrasound to see if what I'm feeling is what I'm thinking. Uh, so if you do that, you ask yourself, is there a chance that you're missing something? Yes, there is a chance because still, as I'm saying, I still can't connect. Why also is the patient having epigastric tenderness? But should that pull me away from saying it can't be maybe hepatocellular carcinoma, for example? It shouldn't, because at the end of the day, it's in the same process. You need the imaging, and the imaging will tell you.
Okay.
Yeah.
Okay, so let's go to investigation, David. So these are the investigation. Actually, the CBC has a lot of derangements. From the hemoglobin is 10 and the other a number of derangement, but remarkably, there's a leukocytosis of 14 and thrombocytosis also of 663. And other parameters, as you can see, and you can appreciate them. And then, David, so this is the liver profile of your patient. So I've tried to crop the real results without even changing a single digit. So this is the liver profile. So there are a number of significant derangements, but significantly there's an elevation of ALP, which is 4,000, and a GGT of around 1,000, and significantly elevated bilirubin levels, as you can appreciate. Next slide, David. So PT is also PTT is slightly elevated, 38.1. Next, David. And then PT is 13.3, within normal range with a normal INR. Next. So other chemistry are seen, so you can appreciate that the serum amylase and lipase are within normal range. Significantly elevated total cholesterol of around 13 with normal creatinine. So BUN was not done as far as this was a cash paying. And then viral hepatitis also, you can appreciate the viral hepatitis, hepatitis B, C, and HIV 1 and 2, they're all normal. Joseph.
Yeah. Okay. Now, quite significant in the remarkable lab that need explanation. And so let's start with this CBC. That's a mild anemia of 10 with a normal MCV, right? So it's a normocytic mild anemia. Probably from the patient being sick for quite some time, which is you say anemia of chronic disease. It's an diagnosis of exclusion, but an anemia of 10 shouldn't bother you much trying to find out why, unless it was a very bad anemia. There's also the white count is also elevated. Michael, you could help me. The differential is, yeah, neutrophilia, and there's also lymphopenia, right? Yeah, that's it. So white count being elevated is a marker that the patient is inflamed. Anything can inflame the patient. The most common thing in that category is an infectious process, mainly an acute infectious process. But also others can be there. And this patient whom we suspect malignancy, uh, who considers as patient who looks inflamed, weight loss, elevated white count, um, a suspicion of a malignancy somewhere in the liver, they can also elevate the white count. So also not much from there. The thrombocytosis of 663, any when you see any rise in any of the blood cells, there are only two things. He says it is getting high out of control, meaning a cancer of the bloodline itself, or getting high because of reacting to something. And I think in this case, this is uh, more possible than the first one. Uh, Reactive thrombocytosis is also an inflammatory marker. So, say patient is inflamed, unless there is another reason for me not to consider that. So, for now, I'll say what the CBC is telling us is that the patient is inflamed from having a anemia of chronic illness, leukocytosis, and reactive thrombocytosis. Uh, can I see the next set of labs? There are so many I can see. Okay. Uh, so here we're also seeing that the liver is also injured in this patient. It's also injured. And what you're seeing is the picture that we're saying an AST being higher than an ALT. Um, if this was more than twice, which is not, I think if it was twice, it would be 380. You increase the suspicion that is an alcoholic liver disease, but uh, 320, maybe not, but we are sure that the liver is also being injured and releasing ALT, AST, plus the alphos and DGT. But you look at the numbers, you realize that alphos DGT very highly elevated compared to ALT, AST. And if you try to figure out maybe why, uh, one can say it doesn't matter. It's just maybe the process. But for me, if I find ALP, um, ALP GGT, because if GGT is elevated, then ALP is elevated, you know that this ALP is coming from the liver, not somewhere else. And this elevation, I think needs explanation. So say whatever the process going on, it's also involving the biliary system inside the liver. That's what comes into my mind. So if it's a cancer, if it's an infiltrative process in the liver, doesn't only involve the hepatocytes only, but also the biliary system inside the liver. So I also put that aside, and maybe it will be helpful later in deciphering the diagnosis. Of importance also the bilirubin of the patient. What to do here is to find out, because in any patient of jaundice, as we said, is elevated bilirubin. So you figure out, is it a direct or an indirect bilirubin, because they both, each one have different differential diagnosis. And what you do is you take the total bilirubin, the direct bilirubin times 2, that will be like 800, 940 something. and so it is not lying on the other side. I can say it's nearly a half, and so you say uh, the direct and the indirect bilirubin, they're like contributing each of them, and in that picture, usually I'm sure it won't be indirect bilirubin as the sole cause. So a mixed pattern like that usually is something also injuring the liver. We had a case here David presented, and we realized also that is not 100% true, but it is helping us to figuring out what is going on. So at the end of the day, if things do not tally, you shouldn't stick with that. That it must be this. It must be because a type of bilirubin is high. It must be the cause of indirect hyperbilirubinemia or a direct. You should be try to be maybe able to change from one direction to another. But the important thing here, what we see is that the liver is injured. They also tested Michael, that still albumin 33. Is that normal in your lab?
Yeah, sure, that's normal.
Okay, okay. In mine that would be low, but it's okay. So different labs. A globulin, which is also high. Um, so what's the importance of being given a globulin in this case? Uh, there are, if you talk about all proteins in the body, there are two. So there are many, but the major one are two. There is albumin and there is globulins. Globulins, these are antibodies, all antibodies. So total protein, if you calculate total protein, mainly you take the albumin plus the globulin. Um, so in this case that we're told, I will find it hard because I usually use the 3.5, but it's okay if 3.3 or 33 is normal. So what Michael is telling us here, the serum albumin is normal and the globulins, they're elevated to this aspect. So I'll say also the inflammatory marker, autoimmune cells will also rise up and globulin will go. Yeah. So I think next, do we have any other set
Joseph,
of labs?
can you repeat what you just said in the last few seconds, talking about the globulins, because your voice broke a little bit.
Yeah, so I was saying, when you talk about total proteins in the body, we mainly talk about, there are so many proteins, but the major ones are two, albumin and globulin, and they're all mentioned here. And oh, the total protein is normal, it's very important. Serum albumin is also normal, but globulin is elevated. And I'm saying if if the globulin are elevated, again, it can be secondary to an inflammatory process, or they're being elevated out of control because of you have causes that we have intrinsic, the globulin are like growing out of control, like what you have the cells in cancer. Um, uh, in diseases like amyloid, for example, or in diseases like no, some of them I'm forgetting them, but that's okay. So for me, the globulin here will be because of this an inflammatory or a malignant process. I expect this. Um, yeah. So if I conclude what I'm seeing, uh, still in a patient whom you palpate the liver and looks like that, and you have a set of labs like this, it's easier to say we are probably dealing with a case of hepatocellular carcinoma, which has caused the liver damage and infiltrating also um, the biliary trees of the liver. Yes, Michael.
Next slide.
Uh-huh.
Other
Okay.
chemists?
Yeah. A PTT which is raised, I think, independent of the PTINR. So uh, the biology of these breeding indices is interesting. I think a PTT measures, um, I think it measures the intrinsic factors, yes, and the intrinsic factors, the one which are so many. Um, uh, if I think of them, which are the intrinsic factors, I think they are factor uh, 2, 5. I think, am I making sense? Yeah, I think no, that's not true. The intrinsic factors, I think, is 8, 9, 11, 12. I believe so. So if they're elevated, independent of the INR, there are two things. Is it a cause that will only affect those factors that are controlling the PGT? Maybe, but less likely, and it's not important in a case like this. But again, you can have other causes that also raises the PGT, uh, which includes in patient maybe with um, okay, these are very difficult things I'm trying to figure out here, but I don't think they'll be helpful in this case. But what I know is if you have an isolated elevated PTT, for example, in the patient whom you are thinking they have an autoimmune disease, you think of which is this diagnosis? So antiphospholipid syndrome, APLS, which doesn't make sense in this case. And there are also some other issues like in a patient with syphilis, for example, they also have a positive PTT, an independent PTNR. Does this pull me away from what I'm thinking? No, I have seen patients they have other things, and you send their bleeding indices, and results come up, and they don't make sense. And you say it's nothing because I'm not dealing with anything. But if that's not the case, for example, in a female autoimmune disease, say why PDT independent elevated. But I will put aside for now this elevated PDT, which is isolated. Yeah. So okay, a total cholesterol this high also need explanation, but it's the patient who has been drinking a lot, if to believe the relatives, and excessive alcohol intake is among the risk factor to have dyslipidemia. Uh, will this uh, will this have anything to do with what the patient is having? For now, I don't think so. Maybe later. Yeah, so the hepatitis. It's important to screen hepatitis in everyone that you think they have a chronic liver disease or hepatocellular carcinoma, because hepatitis B and C, they are all risk factors for this disease.
Okay, thank you, Joseph, for the presentation. So, will you like to do any other investigation? I think yes, but before you go for that particular investigation, the son give you a referral letter from a hospital, a peripheral hospital around Dar es Salaam, where they did an ultrasound and revealed that everything was normal, but they only suspected non-calculus cholecystitis. Will you go for an ultrasound again? So this was a cash paying patient. So I jumped for the next investigation. So David, let's proceed. So I went straight for a CT, and these are the results. So there's a circumferential intraluminal mild enhancing antrum and second part of the duodenum wall thickening and luminal narrowing. No obvious lymph node seen. There's an associated significant common bile duct, right and left intrahepatic duct dilatation. The duct is mildly dilated. So help us with the next click, David. So this was the impression from the radiologist. So there's an antro in duodenal mass with a significant biliary duct dilatation, mild pelvic ascites, and gallbladder sludge. So they had a differential diagnosis of an antro versus an ample of beta mass. So thoracolumbar spondylosis and others are incidental findings. So what's your suggestion apart from the suggestion from the radiologist, which is OGD with biopsy plus the rest of the investigation?
Okay. So you said, what did the ultrasound say? A calculus. You said the ultrasound from another health center?
Yeah, this was from another health center, which was
Would say
a
a calculus cholecystitis.
Yes.
Okay. With a thickened gallbladder wall, right?
Yes.
Okay. Yeah, thank you. Yeah, so many causes of abdominal pain will be revealed in an imaging of some sort. And here we have a abdominal pelvic CT scan with a lot of information. I'm trying to look at the radiographic diagnosis antroampulovatar mass. And so I'm screening up there to see why are they saying it's a mass. And I think it's the first bullet, which says there's the circumferential intraluminomide enhancing antrum, and first and second part duodenal thickening, luminal narrowing. No obvious lymph node seen. Okay. So of importance is we are carried away from initially in this case with the liver. But here we're told the liver is okay, enlarged, but no more density and no focal masses, but we palpated masses. So the answer is those masses that we palpated, they're not coming from the liver. If the imaging is said the liver is free. The question comes now, what we palpated, and maybe even the tenderness in the epigastrium, is this what is presented in the first bullet here? That's the circumferential intraluminal mild enhancing antrum and first and second parts duodenal wall thickening and luminal narrowing. But I'm having trouble here. That's the first. This first bullet doesn't say, because this was a contrasted CT, right, Michael?
Yes.
Then the bullet doesn't say this is a mass. It's also saying enhancing antrum and first and second part duodenal wall thickening, lumbar narrowing, luminal narrowing. Okay. So is this the mass that we palpated, and we thought it's a liver, but it's coming from the intestine, the duodenal wall? If that's the case, then I'll say, okay, let's say it's a mass, but still we'll need to explain a lot of things here. Even if the liver looks okay, but the liver is crying out, also needing explanation that I'm being injured around here. So what's the source of the injury? We initially thought the liver itself have been infiltrated with cancer cells, and so big nodules infiltrating everything to cause the masses and the pain, but that's not the case. So we completely change our equation now. We say the masses are not coming from the liver. So according to this CT, which is contrasted, the masses are what are being seen inside the duodenum. And so if that's the case, the question will be, what is that mass and what is it doing on the liver? Should you say that is the cancer and the process in the liver is the mets? You cannot have a mets without uh, without having without having
Lymph.
not just lymph node, but even focality. We should have seen the focality in such a liver. So I would say it shouldn't be a mets. But we have another process in which you have a malignancy inside the lumen of the intestines, and then they affect the liver in a way that you cannot see it by doing these investigations. And although it's far fetched for me, but I think there is one, but the patient um, uh, doesn't look like that. So maybe I also need that help from the audience here. There is a pathophysiology uh, in which the intestinal tumors secrete like I think is it a chemical or something, and then what you see is a systemic presentation which this patient didn't have. Uh, Flashing and all sort of that. This patient didn't have them. Uh, but again, that process also requires the process to be at the liver. So unless I would say, if I fail at all to say maybe they are connected, you can come and say maybe they are not connected. Maybe what we are seeing on the liver is a alcoholic hepatitis. Patient is drinking a lot, and what we are seeing in the duodenum is something else that maybe truly needs an OGD to biopsy, because if they were related, I should have seen something on the liver. So, like if you want for me, like now to uh, like come and
Commit.
say to commit the diagnosis, I'll say it's hard for me to say if these two things are connected. Uh, what I can do best for now, because the final diagnosis should be independent of what I'm thinking. I should show you how I arrive and not be aggressive. I would
Yeah.
say it's so hard for me to think of any process that the liver is being injured and not seeing anything. If you think the injury is coming from the process you're seeing in the duodenum, so I'll say maybe the patient has two diseases. Also, we tend not to like that process because we want one process which explains everything. But I say it's hard for me now. I say patient have a process in the duodenum, uh, probably a malignancy process, and then the alcohol drinking is also causing them to have alcoholic hepatitis.
Yeah, thank you, Joseph. So the dilemma that you had is actually the dilemma that I had initially. So at this particular point in time, I opted to call a colleague who is a surgeon who usually do OGDs. So I sent this particular patient to OGD to see if truly do we have a duodenal mass or an antral mass anywhere else. So next slide, David. So these are the results from the OGD came back nothing rather than gastritis. And this was the results of the histopathology for the tissue that were taken from multiple points of the duodenum that was suspected. So the final diagnosis from this to make life easier was this patient had only mild chronic active gastritis. And H. pylori was negative, but there are no metaplasia, dysplasia, or any sign that there is an infiltrating issues or malignancy. Joseph.
Okay, this is a difficult case, Michael. But
Definitely.
yeah, so you mean the OGD, they went to the duodenum and didn't see anything, right?
Definitely. Normal. Only gastritis.
Okay. Now, let's assume this is real life. I'll say, should I trust one of these people? So one, I will be the clinician. I will have felt the mass and palpated in the physical exam. And the CT also showed there was a mass, but the OGD is not seeing the mass. So maybe the CT is saying the mass is inside, maybe it's outside. That's the only reason saying it's not being felt.
Yeah, different. So from this point, my a colleague who is a surgeon suggested, okay, you know what? Let's go for MRCP. So I was working in a center where we have everything in house. So next slide, David. So we went for MRCP. And these are now the result of MRCP. So because of time, let's go for the impression only. So there's an extensive intrahepatic and extrahepatic biliary duct dilatation, with the CBD measuring 1.9 centimeter, with abruptly tapering of the distal CBD, without a clearly visualized mass or filling defect. No duodenal mass seen, no ovate pancreatic head mass lesion seen. Overall findings are highly suspicious of distal CBD obstructive process, including the possibility of an occult distal CBD mass or high-grade structure not fully delineated on MRCP. And again, the radiologist is suggesting, can we go for ERCP? Joseph.
The difference between ERCP and MRCP, I think, is ERCP, you can, MRCP just see the problem. ERCP, you can manage the problem. If it's a stone, you can also remove it. So if give me the diagnosis, I shouldn't waste your time.
So the challenges that we see on this particular case actually is what we faced as a team. So the surgeon said, you know what? I know for this particular patient up to this point in time, this patient doesn't sound to be a surgical patient. So this is probably your patient. So go and think about the diagnosis. So up until this time, this patient was cash paying. So what I did is actually going back and reread again. What actually are we missing in this particular case? So David, let's go on and see. So let's link the dots from the beginning. So what explained that this particular patient had all features which were suggestive of cholestatic jaundice, or previously called obstructive, but meanwhile in the same time has some features which are against the cholestatic jaundice. So if you appreciate on the partial obstruction part, here the patient might not have pruritus or itching skin, and then at the other angle, they can also have a normal stool color if they have a partial obstruction. And if there is a complete obstruction, this is what is commonly known, and this is what is commonly taught in our medical school, that we know that the clay-colored stool, dark urine color, I don't know, severe pruritus and other stuff. But this is not the presentation as far as the partial obstruction is concerned. So David, let's move on. So at last, after my readings and everything, what I came about was probably this patient had a perihilar cholangiocarcinoma, Klatskin tumor. So where exactly is it located? As it can be seen on at the mid of the infographics. So this is a perihilar. So the cholangiocarcinoma, it can either be intraductal or extra. So this one is not intraductal; it's outside the ducts. So the one that we palpated initially. And this now explains a number of presentations that this patient presented with. Significant elevated ALP. We can appreciate it on the cholestatic lab. Significant elevated ALP, and conjugated bilirubin was also a bit high in comparison to the unconjugated bilirubin. And then mild elevated AST and ALT. These were mildly elevated in this particular case, 300 by 194. Viral hepatitis were negative. And the other controversial that we had was on imaging finding on the right, on the upper right box. So there is a high mass on CT, but MRCP is not able, so MRCP is not for categorization of masses as per my reading. So this is particularly used only to visualize, to study the bile, and then give you where in particular the structure is. So at this particular point for this case, the biliary structure was at the hepatic hilum. And upstream duct dilatation was the significance that justified this particular finding. So if this case end up to be a perihilar cholangiocarcinoma, We can now classify it as per BC classification, as we can see, and then we can stage the prognosis. So I've tried to stage this particular patient, and this patient falls under T2 and 0M0. Mind you that the CT scan showed no any other no any lymph node at that particular point in time when we saw this patient last year. And then the five-year survival is as shown. So there's one clue that I found, and I think it is important. If you have a hylamus causing proximal bile duct obstruction, one of the differential diagnoses should be a perihilar cholangiocarcinoma. There are others, but this should be on the list. Management is as shown on the little box on the left. David, let's go on because we have more teaching points today. So the question comes is, why MRCP missed the perihilar cholangiocarcinoma? We have on CT, we have a mass. On MRCP, do not have a mass. So I think this is important to share for us as physicians as far as we are concerned, because we are not radiologists. So this is what actually gave me a hard time at the beginning. So how comes? So you have that notion that this can be as an MRI, but it's not true. So MRCP first does not use the MRCP first starts the images. We only start the flow of bile. So static bile. So it can either show you the site of the structure and the level of obstruction. And it cannot also pick the small infiltrative tumors. So it has its own limitations. MRCP does not use contrast. So at this particular point in time, it's very easy to miss a mass. And then the solid tissues appear dark, as far as the other surrounding tissue will also appear a bit dark. So the other important thing is on the image comparison below. So I've tried to generate this image so that we can move together. So you can appreciate the CT. If you have a hilar tumor, which is on outside of the biliary tree, and then if you go for MRCP, this tumor will not be seen. As far as MRCP will not show you there, it's not contrasted. So you will miss. So you need to use both. You need to use CT and MRCP to make the final decision as a clinician. So this is the most important part, because what I can share with you, these are two different radiologists who went. The other radiologist went for the CT scan. The other radiologist went for MRCP. So everyone reported this as separate entities. Then the confusion comes back to the clinician, who should decide on which perspective is the clinician supposed to be. Should I take it as a duodenal tumor? It's not there anymore. Should I take it as a hepatocellular issues? It's not there anymore. So this was more likely to be a tumor which was outside rather than a tumor which was inside. Next slide, David. So this is like a bonus, actually. So during my reading, one of the most important questions I asked myself, why was cholesterol extremely elevated, superb elevated? There are a number of explanations, but one of the easiest way to put this is, this was a secondary hypercholesterolemia. Why? As far as the liver is the one that is involved in metabolism of cholesterol. Now we have, and bile, as we know that one of the constituents of bile is cholesterol. So cholesterol now accumulates and backflow. We have an obstruction somewhere. So we have a backflow of bile and then into the blood. So all of the cholesterol goes directly into the blood. But they go in which particular form? So there's the key pathway on the right box, which is lipoprotein X. So this was a new knowledge to me, actually. So lipoprotein X, this is an abnormal lipoprotein in cholestasis. It's formed during cholestasis. So it's rich in phospholipids and free cholesterol. So once this one goes back into the circulation, this is the one that will go and cause a marked hypercholesterolemia. How do you treat it, and how do you go about it if you are an attending physician or an attending clinician? So for this, the management is very easy. You just need to put a stent if there is a stricture. If you relieve the pathology, this hypercholesterolemia will just resolve. The good thing about it is normally cleared. It's not normally cleared by LDL receptor, and it has no any cardiovascular risk as far as it's concerned. Next slide, David. Joseph. I've tried to go a bit faster so that we can have reflections on this particular case.
Yeah, I'm very impressed, Michael, with you. You're the best, very good clinician. I don't know what I would have done like in that situation, but I know one thing I usually do is, especially for the city, I would have tried to reach another radiologist and ask what's going on. But yeah, this is quite an impressive case, and looking back now, everything goes into its place. So thank you very much, and I wish you present more and more cases. I believe you have a lot of them. If you think this deeply about your cases, very nice. Congratulations to you. Thank you.
Thank you very much, Joseph. David, any reflections from the case or anyone else?
Thank you, Michael. So, as you are presenting, I think the cholestatic markers made me think. Although, if you ask me, what exactly made me think of that, but I had a thought of. I think it crossed my mind at some point, cholangiocarcinoma, but then I couldn't think of a good way to confirm that diagnosis. So I was thinking MRCP, RCP, but then uh, I think you've, yeah, as Joseph said, of course, this was a tough case. And so for people who have been following the case for the hour, you can see how much of a struggle solving clinical cases can be. And this is so Michael did not get this from the New England Journal of Medicine, for example. These are patients that we have in the country, and so we need them. And sessions like these are meant to be practice, because if you encounter that case, if you are not persistent as Michael was, I think it's very easy to give up, and therefore you find these patients are moving from clinician to clinician without a formal diagnosis being made. So thank you very much, Michael, for the case. I think it's been a good learning experience for all of us. And Joseph, the way you dissected through the lab results, I had a lot to take away from that discussion, and I believe others have also done that. So the labs that we order, yes, sometimes I think it's if the cases are not very complex, it can be just a matter of skimming through, and then off you go, you make the diagnosis, you manage the patient. But sometimes you can see that the history is not very helpful, but the labs and the imaging are the ones which are helping you make some progress. So apart from taking histories, being meticulous in physical examination, it's also another skill that we need to master, dissecting through lab results, and also asking questions around radiology investigations, because this is something that I'm also increasingly learning, that the radiologists depend very much on the history that we give them, and it's unfortunate that many times we do not give them a clear history and maybe tell us what exactly we are looking for. So it becomes hard for them to also make their radiological diagnosis, and therefore sometimes you order imaging and something comes correlate clinically, and then you become disappointed that I hoped to make some progress from the imaging, but then the ball is back on my court. Therefore I think we also need to learn also dissecting through the labs, dissecting through imaging, and remembering that it's an iterative process, and therefore we need to go back and forth until we figure out what is going on. So thank you very much, Michael, for the case, and Joseph for the discussion. So Michael, any aware of the whereabouts of the patient and the case resolution? How was this patient managed, and whether they are still surviving or not?
Thank you, David, and thank you for the a nice reflection. So, with regard to the patient, the last time I communicated with the wife was December last year. So when we lastly referred this particular patient to a gastrosurgical department at Muhimbili, so they were received there, but the only news that probably was not good to disclose is that this patient was told that he cannot undergo any operation at this particular point in time. So I think they restaged the patient, and then they found that for this particular point in time, they cannot do any surgery. So it was just a palliative case. So about the patient, whether he's alive or not, I'm not sure.
Yeah, sad news for the patients, but actually, a lot of relief sometimes comes from just someone being aware what they. I mean, it's not very good news. It's not good news at all for someone to know that they have cancer, but it's even harder when someone is sick. They see that they are turning yellow, they have the weight loss and all these other symptoms, and then uh, some clinicians will just tell the patients that we've done every investigation and we are not seeing anything that is wrong with you. And you know what our patients will turn to in circumstances like those. So it's a lot of progress when at least someone is being told that we are not 100% sure, but we think this is what is going on with you. So you did a great job. Is there anything from the audience before we close? I have not seen any hands, or the chat was not very active today. So is there anyone with anything quick before we close? Because we are a number of minutes past the hour. Yeah, Veridiana, please welcome.
Okay, thank you so much. Thank you, Dr. Michael, for the presentation, and thank you so much, Dr. Joseph, for the elaboration. Until coming up to the diagnosis, we see there is a great interaction between the physicians and the surgeons, and a good conclusion was achieved. I was just curious on the progress of the patient on what was actually given for instance, the prior to the referral to Muimbili. Was there any management given, for instance, in the neutrophilia that we saw, the infection that was there, and basing on the state of the patient's liver, maybe what medication was given prior to the referral, and what else was given to maybe stabilize the patient prior to the referral? So I was just trying to ask.
Oh, thank you, Dr. Veridiana. So definitely this was an outpatient, and all the investigation that you see and everything was done within 2 days. And lucky enough, what I can share is clinically, if you look at this patient, what you can only see is wasted and jaundice, nothing else. The labs were like shocking. Actually, there's one part of this case that I did not share is we repeated this lab, assuming that things are not right. Probably we have a lab error initially, specifically for the liver profile. Because clinically, once we look at the patient was not that much sick, but the labs were sick, the image were sick, sick more than the patient explanation. So what we did is I saw the patient on the first day, and then this patient went back home. This patient was cash paying. So the next day we advised on OGD and MRCP. Then the patient paid, and then we referred the patient on the third day. So on the third day, the patient went to Muhimbili. Even in Muhimbili, this patient was not hospitalized yet. So it was not hospitalized. What was done was restaging using the same images that we provided. So in case of medications and treatment in our settings, at that particular point in time, the answer was no. Only PPIs, which for gastritis only.
Okay, thank you so much, Dr. Michael. Thank you.
Thank you. Satrumina, I see your hand. Please welcome.
Thank you so much, Dr. Michael Kisoka, for the nice presentation, and my big congratulations for all of you who have just prepared this kind of presentation. I have learned several things in this presentation. Actually, is the way clinician makes diagnosis to the patient, because Dr. Michael, you did a great job to make the diagnosis for the patient, because the patient was just struggling. He did not know what exactly troubled him, but actually you did a great job to make the artist to make a diagnosis and be able to send the patient to the particular appropriate unit. Thank you so much, and I believe that kind of session will be helpful for us to make us a good clinician.
Thank you very much, Satrumin, for the encouraging comments, and we are happy and impressed by everyone who sticks around for the hour. So we understand. We think this is a good learning experience, but it also needs resilience, because listening to someone else think out loud, and the thinking is actually not very structured. Sometimes it's boring for some, but then yeah, I agree with you that there can be a lot of learning, and they actually, in my opinion, one of the best forms of learning, when you learn with a real problem at hand. I think even retention becomes better. So thank you very much for the comments. And Joseph, next week Michael has another case for you, so I think you will keep on having fun. So we are,
Yeah, sure.
yeah, we are very grateful to Michael for the big job that he's doing. So a very interesting case for learning. Very sad for the patient, but uh, we learn a lot from these cases, and therefore these will benefit other patients that we come across. So next week Michael is having another case for you, and again I'm making another call for everyone who is still in the chat. I know that you people are seeing some interesting cases, and so please bring them, because we learn a lot from them. And another thing is, we also need to see some new discussants. So yeah, for a while I think the major discussants have been Joseph and me, and then Michael has discussed some cases, Seba has done it in the past, and Fabian also has discussed some cases, but would like to hear from other people, because we know that you people have a lot of knowledge, and we can learn a lot from you. So even next week you can actually volunteer to co-discuss a case with Joseph, and also bring your cases so we can learn from them. Otherwise, thank you very much everyone for sticking around, and see you next week, and have a good night.
Good night.